says the same thing, nothing new.
I know he seemed real concerned about her, and we're thinking, and he said he thought that's why she's having that pain. She's got urine in her
Yeah,
kidney.
we'll ask him about.
Oh,
He
okay.
hasn't mentioned that. We'll ask him
Okay,
about it.
okay.
Was that the PET scan that showed that?
Mhm.
Yeah, basically showed that.
Showed that her right kidney was swollen,
Yeah.
and that was probably blocked.
Part of that.
They don't
So-
show I have a tumor there.
Oh,
So,
yeah, that's right.
The PET scan doesn't show a primary tumor.
No, that came from Houston, the tumor.
This weekend, her side was hurting real bad, and we took her into the emergency room at MD Anderson, and he said, that it was, like he said, I'm just an emergency room doctor, but I can tell you on the CAT scan, I saw a tumor on your small intestine. And we had, I don't recall hearing that before.
No, he didn't say
My
that.
mom said
No,
that's the
but-
first time I heard that.
It's real hard to look at the small intestine on the CAT scan because it moves around, so sometimes it's hard to tell
Okay,
exactly because it's in
okay.
the small intestine. So when they did the PET scan, they found the stuff we talked about, the lymph nodes that were all positive, and the T8, which is kind of like the bottom part of your shoulder blade, right about here. And then the humeral head on the left.
Yeah.
You have a right renal hydronephrosis, which means that there's the urine that drains from the kidney can't drain, so it kind of backs up, and the kidney was swollen. And it was there on the previous CAT scan, I don't know, it was the previous CAT scan.
I don't have trouble getting it, I don't know.
Well, yeah, but the other one still works, so you won't
Yeah.
notice any difference. But that sometimes causes pain, if that kidney's blocked.
Oh, okay.
And it doesn't tell us why that's blocked. Sometimes those lymph nodes, yeah, so he even says the cause of the obstruction is uncertain. This is it. He doesn't see any lymph node that's plugging that tube up. It's
Oh, okay.
not clear why it's happening. So what happens is, if we look at, oops. Draw some pictures. So when we look at your kidneys, my kidneys, these kidneys, they look like this. You have the tube that comes down to the bladder. And there's another one on the other side. And there's something sitting here, maybe here, I don't know where, but they don't see it. It's plugging up that tube, and so the urine backs up, and so this was all swollen, and this was not. Okay. And what
So
they-
we don't think that's a lymph node?
Well, it could be. My guess is it probably is, but they're saying on the scan they don't actually see the mass that's doing it.
Oh, okay.
So it could be scar tissue. It probably isn't. It's probably related to the disease, but they don't really see specifically that's doing it. And so what the urologists do is they go in through the urethra with the scope, and they put a stent in here, which is basically a tube that looks like this, has a bunch of holes in it. And so you have this blockage. It's blocking it, but you get the stent past it so the urine can come out here, and it bypasses that blockage, and that urine's allowed to drain, the kidney shrinks back up. These do sometimes hurt. They don't hurt if they've been there a long time, they usually when they first happened. This was there in a prior CT scan, a little bit, it's a little worse now. It's on the right.
And that's where
your
she's
pain
having
is.
her pain.
So that pain is probably from that kidney.
Oh.
So is that kidney in any danger of rupturing or failing?
Won't rupture. It may fail. If you keep it blocked up long enough, the pressure back on the kidney damages the kidney where it doesn't work, and you have to use the other kidney. But it won't rupture.
So if it's in danger of failing, is that an urgent concern or?
I would address it pretty soon. Again, it was there on the previous CAT scan. They didn't tell me when the CAT scan was. They said they noticed this on the previous CAT scan, and it's a little worse, but I don't know if the previous CAT scan
I
was
have-
2 years ago
I have-
or 3 weeks ago.
So when you say address it pretty soon, what are you thinking we need to do?
Go see a urologist.
Okay, can you refer us
Can you
to?
refer us one here?
But in the next, week or so, I wouldn't wait too long.
Right,
You don't
right.
have to be, you don't have to be put to the hospital and get it done tonight.
Right, and that's kind of what happened when I started hurting that other day. We said,
Yeah.
well, we knew there was an issue. We want to make
If
sure
the
we
kidney may already
started.
be damaged. Well, okay, so putting that stent in isn't going to help the kidney recover, but it'll help her from it probably isn't completely damaged. You may have 50% of kidney function on that side. Well, let's keep it at 50 and I'll let it go down to 10, So there may be some permanent damage, there may not be, but it's hurting. And you can save the rest of the kidney, whatever is still working, or could recover, and you stop the pain from the blockage. So most
Okay.
urologists would put a stent in, that's usually pretty easy to do. There's no
Okay.
incision,
Okay.
yeah.
Okay,
So I would see a urologist as soon as you can. It's not emergent, but don't procrastinate.
right.
Okay. And you said you could refer us to one
Yeah,
here,
yeah.
okay.
So that's probably due, there's a bunch of lymph nodes in the back of the abdomen. It's like a bundle of grapes. Yours are like that, but yours are real small. Well, hers are bigger. And so one of those is probably obstructing that, but they just don't see it specifically on the scan.
So everyone has lymph nodes.
Yeah.
Just some of them are enlarged, and that's the
Everybody has lymph
concern.
nodes, they get enlarged for different reasons. You get strep throat, your lymph nodes get big. Those are. You get a tooth abscess, your lymph node swells up. So as infections make them get bigger, mono, they get big.
Do we have a finite number of lymph nodes, or is it?
Sure, but it's a big number.
Okay, so we have a lot of lymph nodes. Okay.
And so she has a bunch of those lymph nodes that are enlarged, but in her case, they're enlarged because cancer spread to the lymph nodes. The lymph nodes kind of drain an area. So if you have cancer in your tongue, and these lymph nodes are enlarged because the cancer cells will drain into the lymph nodes and grow there.
Okay.
Colon cancer that drains into the lymph nodes in the abdomen. So she has a little bit unusual, but she has lots of lymph nodes. Here, 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 and in the pelvis. And most of the time when you find lymph nodes, you can kind of tell where the tumor starts. If you have lung cancer, it's usually going to be these lymph nodes that become positive first. If you have colon cancer, it's usually lymph nodes in the abdomen. And so hers are positive in multiple areas, which is a little bit unusual. So you have some type of cancer that is spread to the lymph nodes all over. It's more typical of a lymphoma than a carcinoma. That's what we thought. She probably had lymphoma when I saw her the first time.
I'm sorry, what's lymphoma?
Cancer of the lymph nodes. And they
Okay.
often spread to a bunch of different lymph nodes.
Yeah.
Whereas carcinoma, which is cancer of an organ, tends to spread to the local lymph node. Breast cancer spreads over the arm. It doesn't spread to the lymph nodes of the abdomen. You see what I'm saying? So it's a little bit funny that she has a bunch of lymph nodes and it's carcinoma. That's usually lymphoma. In her case, it's not. It's carcinoma. And so the areas that this looks like, the pathologist can't say for sure. They've done stains and it suggests that these cancer cells started in the upper abdominal tract.
Right.
Upper abdominal tract, which is lower esophagus and the stomach, which we're looking at in the disease. The bile ducts and the pancreas.
Well, he said that he was pretty sure it was upper GI because pancreas usually doesn't go to the bone. But then he assumed that the shoulder thing was the bone. But you said because there's no
Well,
pain that maybe that's not cancer that he's seeing.
Pancreas doesn't usually go to the bone, nor does stomach or bile duct without going to the liver first. And there's nothing in the liver. So none of those are behaving like this. Typically, they don't do this. So whatever she has is just behaving unusually. It could be an unusual tumor. It probably isn't. It's probably a tumor that we suspect that's behaving in a little bit atypical fashion.
Right.
Okay. So it's probably one of those tumors. On the PET scan, we did not see the primary site. That's a problem. Not a big problem, but we can do all sorts of tests looking for the primary site. There's really no reason to do that if it's not going to change the treatment. And so we can do scopes, biopsies, other scopes, bronchoscopies, a whole bunch of stuff, and in a third of the patients, we still never find the primary site. Because what happens is some cancer cell became malignant. It was mean and looks mean. Your immune system says that's bad, we have to kill it. And it tries to kill it. And it does kill it, but once cancer cells escape, it spread to the lymph nodes. And that continues to grow. So we find the cancer in the lymph node, we never find the primary because the primary's been killed. So we may never find it. Okay. So what we need to do is do a bunch of tests to make sure it's not a disease that we would treat differently. Okay. So, for example, thyroid hormone, we treat like radioactive iodine. We want to make sure it's not thyroid cancer. Breast cancer, we treat very different drugs to make sure it's not breast cancer, because they've done those stains. Cancer of the stomach, we would treat different than cancer of the pancreas or cancer of the bile duct. So we want to make sure it's not cancer of the stomach. So there's certain things we want to make sure it's not, but is it bile duct cancer or pancreatic cancer? Well, we treat those about the same. So it's not that important that we have to know the difference. But we treat stomach cancer differently. So what we typically do in this setting is we do a CAT scan, done that already. Then we get a gastroenterologist to look under the scope to make sure it's not a stomach cancer, which can do this. And if it's stomach cancer, we treat it with different chemotherapies. If it's not stomach cancer, and we can tell from the stains it's not breast cancer, and it doesn't look like any other type of hormonally responsive cancer. We don't have to worry about prostate cancer in her, but in a man, prostate cancer you treat with different drugs. Then we would say, well, you have carcinoma of unknown primary. We don't know exactly what the primary is. So we get the pathologist to tell us where they think it is. They would say, what's most likely going to be this area, so we'll treat it like that. So if it's for most likely lung cancer, we'd use a different type of chemotherapy than is most likely upper GI tract, which is a little different than is most likely lower GI tract, colon. So, so I think she ought to have that stent put in to protect her kidney, probably relieve her pain, and then have an EGD, as we call it, endoscopy, where they stick a scope and look and make sure there's no cancer in the stomach. And if that's negative, then consider treating it with chemotherapy directed towards pancreas and bile duct. Those are not great diseases, okay? And we may even try to do some blood tests, which we can order today, because there's some tumor markers, and they're usually not diagnostic. I have another patient who's in his 50s, who showed up with fluid cancer around his fluid around his lung, never found a primary, so I ordered this blood test. So there's, for example, CEA is a chemical that goes up with 2/3 of colon cancers. Well, if it's normal, it doesn't mean it's not colon cancer, but it usually goes up in 2/3 of them. Well, it goes up with breast cancer and lung cancer. Okay, normal 0 to 4, may go up to 40, 100. There's another marker for pancreatic cancer, CA19-9, and it goes up, the normal's about 40. It goes up to a couple hundred with cancer of the pancreas most of the time. Well, this guy's came back 68,000. That's cancer of the pancreas. Other cancers can make go up, but not like that.
Yeah.
So we can order blood tests. They're very easy to do. We can order those blood tests. They frequently are not conclusive. If it comes back as 100, it doesn't really tell us where the primary was. If it comes back way up and the other ones aren't, we go, that's probably what it is. And we treat it like that. So we can get some blood tests that may help us. They may not, but they're easy to do. And then I would do a scope, get the stent in the kidney, do the blood test, and then determine what type of treatment to take. The things that we worry about, let's say we can't treat the disease. Let's say no matter what we do, the cancer isn't controlled. We treat the patient. That's all right. So how do we treat the patient? We preserve your kidney function by putting that stent in. That thing in your back, if there's a tumor there and it grows, it can compress the spinal cord and cause it to be paralyzed. So we'd radiate the spine to make sure that doesn't go and cause paralysis. If this hurts, we can radiate that so that won't fracture. So we can treat problems that come up. Some of them aren't very important, but the one in the spine is. Because if there's a tumor in the spine, it doesn't have to go very big to push on the spinal cord and cause paralysis. So if we give you chemotherapy and we think it's going to work, there's a pretty good chance it will, depending on the type of disease it is, then we can just treat that and see if that spine problem goes away. But if you have a disease where chemotherapy doesn't work very well, we may want to radiate the spine first to protect the spinal cord and then do the chemotherapy. It depends on what we're treating.
Did you catch all that?
Yeah, and I know there's a lot of different chemotherapies, and I guess it's depending on what y'all find and how y'all, but I will tell you, as a general rule, she prefers not to have chemotherapy, which I'm sure everybody does.
That's what I
No,
don't
I understand.
Chemotherapy.
And so what I'm trying to do is be honest and say, you have, for example, cancer of the pancreas. The chemotherapy works about 20% of the time. Here are the side effects. If it works, it lasts for 4 months. Do you want to go through these side effects for a 20% chance that it'll add 4 months to your life? You may say no. If it's stomach cancer, there's about a 60% chance it's going to work, and it usually lasts for 2 years. Now, here are the side effects. Are you going to go through those side effects for a 60% chance it'll add 2 years to your life? Well, you may want to do that. So I'm trying to give you a fair understanding of what we're talking about, but again, it's not a prediction, it's an estimate. If I say if it's gastric cancer, it'll shrink 60% of the time, that means 40% of people it doesn't shrink. We don't know what's going to happen, but give you a reasonable idea of what you're looking at to determine if you want to do it or not. There's also several new chemotherapies out. May not be approved yet for this disease, but they're immunologic mediators. They stimulate the immune system to attack the cancer. They're much easier to tolerate than the conventional chemotherapy. And so if we can use one of those are easy to take. So there's some choices, but I understand what you're saying. Giving you chemotherapy because I know how isn't a good enough reason. You know, it needs to have a reasonable chance of working with tolerable side effects that are tolerable. And you can tolerate more side effects than she can.
Right.
I mean, it's just, well, I understand that. So I understand what you're saying.
Yeah.
And I'm not going to say, you need to take chemotherapy. I'm going to say, here are the options you have. Here's the advantages and disadvantages. And we'll decide what you want to do. Does that make sense?
And she's got a lot of kids. And some of them are pretty bright, and we're all doing research on, cancer cures, and there's a lot of alternate cures, and I don't know if what your thoughts
What's the
are.
definition of an alternate cure?
Well, and that's what I said, there's a lot of like, juicing
But what
or,
I'm saying is, an alternate cure means one that hasn't been proven. If it's been proven, we use it, it's not called alternate.
that,
It's weird, isn't it?
yeah, or,
So if you
or
use-
natural cures,
I don't know the difference. If you use an alternate cure and it works, we use it and there's no longer an alternate cure anymore. We cure cancer all the time. Lance Armstrong had cancer in his brain before he did the Tour de France 7 times. We cured his cancer. We do that all the time. Then that's not called an alternative treatment. It's an alternative treatment when nobody's proven that it's worked. Because when somebody proves it works, we use it. But we do science. You gotta prove it works. I have a friend who got better. So, I have a friend who drove drunk and didn't have a car wreck.
right,
Does that mean everybody drives drunk and doesn't have a car wreck? One person doesn't mean a thing. When you have this guy in Sugar Land, Brzezinski, who has anti-neoplaston, where he takes your tumor, injects it to a horse, and takes the horse's urine and gives it to you, why would you think that would work? That's what he would do. And hey, all these people that try to close down his factory, all these people carrying signs says, "No, I'm still alive because of him." The people who didn't die, who didn't survive, they're not there protesting. They're dead. So you're getting a very skewed perspective. You're only seeing the touchdowns. They're not showing you any of the fumbles.
right,
Okay, and so you have to be very, very careful. But we look at science and we look at it very critically. And if you show something that works, we're going to use it.
Right.
And so an alternative treatment usually means something that's never been proven. It doesn't mean it doesn't work. Every treatment that we use now, at some point, hadn't been proven yet.
right.
Okay, but I have no problem people doing research. They're not doing research; they're reading articles.
Right.
Doing research means you take 100 patients and you treat them with this drug, and 100 patients with that drug. That's research. They're reading research that other people have done.
Right.
Okay, and most of those aren't very valid. Okay?
No, I get
I'm
it.
just giving my point.
No. I have a friend of mine that I asked, and he said the same thing. He said, ask for the studies. And if they don't have studies, then
And they say,
what are you
Dr.
basing it
Smith
on?
recommends you take this. That's not a study.
Right,
I'm Larry King, I take garlic and I feel great. That's not a study, that's a testimonial. Let me say it differently. I'm Larry King, I take garlic and I have been divorced 7 times. That's also a true statement.
right.
Okay, so garlic makes you get divorced? Or garlic makes you feel great? I flip the coin and landed on heads. Does that mean all coins land on heads? That's what a testimonial is. We make fun of testimonials.
Right.
This doctor says this is a good treatment. This coin flip lands on heads. Who cares? This is a good treatment. You should be able to give it to 1,000 people and compare it to people who didn't get it and show that they did better in that group. That anti-neoplaston that the guy did with the horse stuff, after years and years and years of not letting the FDA look at it. Now think how unethical this is. I have a treatment that treats cancer and nobody else can use it. Isn't that unethical?
Mm-hmm.
You have to come to me, nobody else can use it. It's an experimental drug, I don't have to turn it over to you. That's what he did for years. My uncle, who died of prostate cancer 20 years ago, got in Ohio, got a advertisement on TV for this guy, saying, should I go see this guy? He's got an ad on the TV, I've got prostate cancer. That was 20 years ago. He's just now been put out of business recently. Finally, after many, many lawsuits, the FDA finally forced him. Oh, and the guy in Ohio, my uncle says, they said they can't charge me for the drug, but the visit's $10,000. This visit will not be $10,000. Okay. He couldn't charge for the drug because it was never proven, so he would charge $10,000 for the consultation and then give you the drug for free. So the FDA finally made him turn it over. And they said, you give us the drug, you tell us which disease to use it in and how to use it, and we'll test it. They test it. They give 100 patients, they give this drug to them, the best drug, best disease he has, response rate's less than 10%. He's been giving it to people for 40 years and charging them $10,000 to get it. And not letting anybody else study it. You have to be very suspicious if someone has a secret discovery that nobody else can use.
That's what my husband said. That's exactly what my husband said. He goes,
So there's nothing wrong with those. I have no trouble to trying those treatments. They should be done in addition to conventional therapy, not
yeah.
instead of.
got
Does
it.
that make sense?
Yeah, that's
Okay. So I have no problem with that, but
So basically, your thoughts right now are, number 1, get a stent put in, number 2, do some more testing for the cancer, and then number 3,
blood
upper GI thing.
stent and the scope.
Okay,
And then we'll have enough information to say, here's what we think you ought to take.
okay.
And hopefully it can give you choices. Here's the 3 treatments that may help,
One thing
and
at a
here's the
time.
advantages and disadvantages.
Yeah.
One thing
Get
at a
me
time.
confused so many things.
Yeah,
That's
that's a
why
good-
we
that's
bought
a good
Jesse
summary.
Broncos. I would be confused too.
Jessica.
No, Jesse's pretty sharp.
But
He
this is something bad. I mean, this isn't good. We'd rather you not have it. And there's a possibility that we'll tell you that we don't have very effective therapy. But we'll make sure that if we do have effective therapy, we get the right test done so we can give you the treatment that should help.
Right. That's all we can do.
Now, the good news on the PET scan is there's no real organ involvement. Bone and lymph nodes. So those are important, but it's a harder disease to treat. It involves liver, lung, brain.
Was there any bone other than the shoulder?
The spine, that T8, that eighth vertebral body, that one between the shoulder blades. There's one area at T8, which is right about shoulder blades, right about here, in your spine, and then the left.
But you said in the shoulder, since there's no pain, that might not be cancer?
Well, it might not be. It could be infection. It could be inflammation. It could be some other cause that makes this PET scan turn positive.
Same thing with
scans are
her
pretty-
spine.
PET, yeah, PET scans are pretty good, but they're not perfect.
Right.
Alrighty,
So you need some names of people.
yes,
You're going to be in town?
yes, we can be